Going to go now to our next speaker, who is Dr. Maja Bowen. Now, Zan Dalia is going to introduce her, so I'm going to hand over to Zan to do that introduction.
About 3 weeks ago on Twitter, a story broke. The headline was, "Trans women's milk as good as breast milk, says NHS Trust." The byline said, "Drug-induced chest feeding liquid comparable to that from mothers when it comes to baby nourishment, claim hospitals." Not one hospital, but hospitals. Okay, so then there was the necessary spate of formal and informal commentators, including Millie Hill, Emma Hilton, and La Scapagliata, who is Maya, who wrote, who tweeted, "As the gaslighting and child endangerment via state-sanctioned promotion of male lactation fetish ramps up again, here's an excerpt from my book that analyzes this issue from a medical perspective." And so that's what Maya is going to share with us, Maya and Lorelei. So take it away, girls.
I first wrote about this in 2018, when the first famous study in this area came out. And later on, I modified that essay and expanded on it for my book, Born in the Right Body, which came under my pseudonym Isidora Sanger. So we agreed that I will just read that essay and then take questions, or I'll be in the breakout room as well, and we can talk there. So here it goes. In 2018, media outlets all over the world reported on a case study where a doctor and a nurse at a clinic in the United States used a cocktail of drugs to enable a male patient, who identified as a woman, to breastfeed a newborn baby. A UK expert commented that this was an exciting research which could lead to more cases of transgender women breastfeeding. According to the authors of the study, who are called Reisman and Goldstein, the male patient, who they refer to as a she throughout the write-up, claimed that his partner, who was the baby's mother, was pregnant but not interested in breastfeeding, and that he was hoping to take on the role of being the primary food source for this infant. However, reading the paper, I could not find any evidence that the authors interviewed the mother to verify their patient's claims, or that they obtained informed consent from the mother by discussing the risks that male drug-induced galactorrhea, which is an abnormal nipple discharge unrelated to milk production during pregnancy and breastfeeding, could pose to the baby. They did report that their patient had a history of gender incongruence, but had no gender reassignment surgeries, which means that he was a fully sexed male at the time of this study. His gender-affirming regimen included spironolactone, which is a heart medication used in this case as an androgen blocker, estradiol, and micronized progesterone. This man was also taking occasional clonazepam and zolpidem for panic disorder and insomnia. At the initial appointment, the patient had gynecomastia, which is an abnormal enlargement of a man's breasts, usually due to hormonal imbalance or certain medication, which was likely a side effect of the spironolactone and cross-sex hormones he was taking. His serum testosterone level on initial examination was unclear because two markedly different values were given, 256 nanograms per deciliter in the body of the text and 20.52 nanograms per deciliter in the results table 1. The authors reported no further testosterone data, which indicated that they did not measure the patient's testosterone level at any other point in the study. In order to make sense of this glaring inconsistency, I took into account the evidence that 3/4 of trans-identified men on spironolactone and estradiol failed to reach testosterone levels within the female range. I concluded that the higher figure is likely to be correct and that this patient's testosterone was not adequately suppressed, despite the authors emphasizing that androgen blockade was an important part of the prescribed regimen. While the testosterone level of 256 might be slightly low for a man, the normal male range is 265 to 923, it still far exceeds the normal female testosterone range, which is 15 to 70. In cases of polycystic ovarian syndrome or PCOS, the female testosterone levels are increased, but they're still lower than 150, whereas female testosterone levels that exceed 200 are suggestive of an ovarian or adrenal tumor. There is a paucity of research into the effects of elevated testosterone on breast milk and on breastfed infants. In one case report, a postpartum woman with depressive symptoms was given testosterone, both orally and vaginally in unknown doses, as well as subcutaneously, which means under the skin, via 100 milligram testosterone pellet to improve her mood. The study concluded that, quote, testosterone was very low in infant blood at baseline and during testosterone therapy by pellet implant. There were no adverse clinical effects in the infant after 7 months of continuous testosterone therapy to the mother by subcutaneous pellet implant. Testosterone delivered by sublingual drops, vaginal cream, and pellet implant was absorbed but not measurably excreted into breast milk, end quote. However, crucial details are missing from this study, such as the age and sex of the infant, as well as the extent of breastfeeding. I will also add that follow-up, long-term follow-up needs to take place for us to really know what long-term effects this might have had. Another case study concerns a trans-identified female patient who was described as a transgender man, resuming weekly testosterone injections at 13 months postpartum as a part of her gender-affirming therapy. This study showed that, quote, milk testosterone concentrations also increased with a maximum concentration of 35.9 when the lactating parent was on a dose of 80 milligrams subcutaneous testosterone cypionate weekly. The calculated milk/plasma ratio remained under 1, and the calculated relative infant dose remained under 1%. The infant had no observable side effects, and his serum testosterone concentrations remained undetectable throughout the study period. End quote. This study likewise did not report the extent of the breastfeeding, and significantly, the infant in this study was male and 13 months old. We already know that elevated testosterone in pregnant women inhibits breastfeeding, and it exposes fetuses to an hyperandrogenic environment in the womb. This can cause a variety of medical complications in girls, such as polycystic ovaries, insulin resistance, and congenital adrenal hyperplasia, as well as increased likelihood of gender nonconforming behavior in childhood. Considering that currently gender nonconformance increases the likelihood of a child being diagnosed as transgender, that this frequently results in pediatric gender reassignment, and that the effects of elevated breast milk testosterone on newborns of both sexes are not known, there are serious ethical issues here, including with the decision by clinicians to enable a man whose testosterone suppression isn't adequately demonstrated to breastfeed a potentially female infant. This brings me to another glaring omission in this report. While the authors consistently refer to their trans-identified male patient as a she, they never state the sex of the infant involved in this experiment. In addition to my concerns about high levels of testosterone in breast milk, this male patient is also reported to have used domperidone to stimulate galactorrhea. Domperidone is banned in the USA and is only used off-label internationally to induce lactation in women. Domperidone is sometimes used to treat reflux, but it has been discontinued for use in children under the age of 12 due to potential heart side effects. When domperidone is given off license to stimulate lactation, it requires ensuring that mother and infant don't have any contraindications to this treatment. And yet there was no evidence that the authors attempted to ascertain this. There's also no evidence that the patient stopped using clonazepam, which is a drug that can cause sedation in infants, or zolpidem, also known as Ambien, which could exacerbate the effects of clonazepam prior to commencement of breastfeeding. When we talk about the safety of medicines in breastfeeding, we weigh the benefits of mother's milk to the health of the child and of bonding between the mother and the baby against the risks of discontinuing the medication. If it is at all possible and medically justified, mothers who take medicines that could be passed to their babies via breast milk often decide or are advised either to discontinue medication or to not breastfeed in order to avoid adversely affecting the baby's health. Now, contrast this with a man taking unnecessary medications to induce galactorrhea just so that he can fulfill his desire to breastfeed. A word on males' desire to breastfeed. Psychosexual disorders such as transvestism and autogynephilia are present in a proportion of men who identify as women, and a breastfeeding fetish can be a feature of this condition, as the excerpt from the news article written by one such man illustrates. I quote, "Breastfeeding is freaky, not the sucking bit. You are reading The Stranger, so odds are you've had a titty sucked at some point in your life. No, it's because when my baby attached to my breast, there was an incredible chemical cascade that ran through my entire body like lightning. Imagine the most electric thing a partner has ever done to you, then multiply it by 10. I could feel my brain rewiring, creating pathways that would permanently connect me to my child. And yeah, I kind of got off on it. Don't judge." End quote. It should be said that there is some historical evidence of men occasionally breastfeeding babies in situations where breast milk or other adequate nourishment was not available, such as on long sea voyages after the death of a baby's mother. These men would have had medical conditions that abnormally elevated their prolactin levels and caused galactorrhea, such as pituitary tumors, and would have resorted to this in a desperate attempt to keep the baby alive, not because it was their desire to do so, despite an availability of appropriate food sources for the infant. It is thought that this purely helped infants survive mainly by maintaining hydration, not because it was an adequate substitute for the breast milk of lactating women. In the wake of this study, numerous attempts were made to equate drug-induced galactorrhea in men with the natural breast milk a mother produces after giving birth. This ideological narrative has gone so far that we have witnessed systemic replacement of the words breast milk and breastfeeding with phrases such as chest milk and chest feeding, and also human milk, in an attempt to normalize this practice. However, the research on the composition of male nipple discharge is very scarce, and the research into the effects of this type of fluid on infants is non-existent. In one study from 1981, the researchers collected monthly nipple discharge samples for 3 months from a 27-year-old man with elevated prolactin and likely pituitary cancer, pituitary adenoma. They then compared these samples to colostrum, which was collected during the last semester of pregnancy and 1 day postpartum, and breast milk collected between 1 and 12 months postpartum from normal lactating mothers. They concluded that, quote, "The concentration of lactose proteins and electrolytes in the breast secretion of this man are within the range of colostrum and milk obtained from normal lactating women," end quote. However, looking at the results in more detail, the lactose level in the male patient's nipple discharge was nearly double that of colostrum, and sodium was just below the lower end of the normal range. More importantly, Unlike mother's milk, male nipple discharge hasn't occurred as a consequence of growing a baby inside his body, and it is in no way tailored to an individual child or any child for that matter. Breast milk is the unique nourishment lactating mothers produce in order to sustain their own babies and protect them from disease in the weeks and months after birth, when the infant immune system is still not fully developed. First milk is called colostrum, and it starts being produced during pregnancy and then up until 4 days post-birth, which is a thick yellowish fluid full of fat, vitamins, and particularly rich in antibodies. Colostrum changes to a more calorific transitional milk over the following 2 weeks, which is high in fat and vitamins, and after that it becomes mature milk, which is 90% water. Maternal antibodies are first passed via the placenta to the baby during the last 3 months of pregnancy. And after the baby is born, he or she continues to receive antibodies through breast milk. As mother and baby share both the genetics and the environment, these antibodies are customized by the mother's body to offer an individually tailored passive immunity and protection from the pathogens the baby is most likely to encounter. Therefore, I found it strange that Reisman and Goldstein made no attempt to analyze the composition of their male patients' drug-induced nipple discharge, considering that they talked at length about the benefits of breastfeeding on mother and baby, none of which were applicable to their male patient, or indeed the infant he allegedly fed. Be that as it may, as a consequence of a cocktail of drugs and the breast pump, this patient is reported to have started to lactate, eventually producing 8 ounces of nipple discharge daily, 2 weeks prior to the birth of the baby. Although we have no further details about the volume, the study claims that whatever fluid was produced, it was the sole source of this baby's nourishment for 6 weeks. After this time, the patient reportedly started to supplement with 4 to 8 ounces of Similac brand formula daily. The authors give no indication that they observed this alleged breastfeeding or that they met the mother or the infant. They did state that, quote, the child's pediatrician reported that the child's growth, feeding, and bowel habits were developmentally appropriate, end quote, but they offered no corroborating evidence. Considering that a 5-pound baby needs about 12 ounces of breast milk or formula a day, and more as the baby's weight increases, it is extremely unlikely that any infant would survive for 6 weeks on 8 ounces alone. Furthermore, mothers who are unable to breastfeed know only too well how important it is to use adequate amounts of baby formula. Failing to do so can result in serious harm to the baby. I have no evidence that the baby who was allegedly subject to this experiment was harmed in any way. However, there are so many omissions, unknowns, and missing data that I cannot help but ask, why was a trans-identified man held to a drastically different standard of infant care than actual mothers? That this experiment was conducted by a transgender clinic, which neither has the license nor expertise to oversee the breastfeeding of a newborn, only adds to my concerns regarding ethics, safety, and biases in this study. It is my opinion that rather than constituting exciting new research, this study is fraught with incomplete and misleading information, disingenuous analysis, and undeclared conflicts of interest. That it was also reported as fact in the media, without any meaningful challenge from the mainstream medical community, makes me wonder if transgender research has lost sight of the bigger picture and has come to prioritize the emotional needs of trans-identified males over the welfare of women and children. I have a little addendum to my original essay that I added after the book was published, and that is to comment on 2 further studies. One study published in 2023 was titled Lactation Induction in a Transgender Woman, Macronutrient Analysis and Patient Perspectives by Amy K. Weimer, MD. All the criticisms from my above article apply, with the exception that this male participant had his testicles removed at 41, which was 5 years prior to this experiment, and therefore high testosterone level and related concerns were not a factor. How otherwise, the following problems persisted. Number one, there was no evidence of maternal consent. Number two, there was no mention of the sex of the baby. Number three, referring to the male participant as she and mother as a gestational carrier. Number four, it involved pathological male nipple discharge, which resulted from a severe hormone imbalance, and medications which caused galactorrhea was equated with normal physiological mother's milk. Number five, there was no observance of this alleged male breastfeeding. Number six, the analysis of male nipple discharge was yet again incomplete. For example, the presence of medications including doperidone, cross-sex hormones, or antibodies in the male breast fluid was not measured. Sodium was not measured, and it was lowish in another study. Other nutrients were, quote, at the same level or higher, which is not necessarily a good thing. And the comparison was with mature mother's milk, 70 to 94 days after delivery, not with colostrum or transitional milk appropriate for a newborn. Number seven, uniqueness of mother's milk to the baby and its fundamental difference from male nipple discharge wasn't explored. Number eight, the volume of this fluid was yet again inadequate at just 150 ml per day. But this was mitigated by the fact that mother was actually breastfeeding this baby the entire time as well. So number nine, if the infant had access to adequate nutrition, immune support, and bonding via breastfeeding from their own mother, and developmentally appropriate formula was available, should anything go wrong, the only reason this experiment was conducted was to satisfy the desire of a man not to benefit the baby. And number 10, in this male patient's own words, it, quote, would be a wonderful personal experience and it would be a great help for my partner, end quote. Since men can feed the baby with expressed mother's milk in order to help their partners, there was no practical or medical need whatsoever to conduct this experiment. The second study, called Lactation Induced in a Transgender Woman Wanting to Breastfeed case report, authored by Rachel Wombolt in January 2021, has exactly the same, very similar issues to Reisman and Goldstein. Number one, this was another case of gynecomastia and minimal volume, 3 to 5 ounces of male galactorrhea secondary to iatrogenic or clinician-induced hormone imbalance, and side effects of multiple medications, including, yet again, domperidone, cross-sex hormones, and androgen blockers. Number two, no study of composition of this fluid that was fed to the infant was done. Number three, there was again no corroborating evidence. Nobody observed this breastfeeding. There was no evidence of informed consent given by the mother, no exploration of ethics of involving an infant in an experiment that is chiefly designed to satisfy the desire of a man to breastfeed. Number four, this study states when talking about the male patient, quote, although this was not enough to meet the nutritional needs of her child, she felt encouraged that she was potentially contributing to the immunological health of her child. There is no evidence in existence that abnormal drug-induced male nipple discharge contributes to immunological health of babies who ingest it. Crucially, none of the usual scientific protocols that are used to ascertain whether medications and food given to infants are safe have been followed in any of the studies in this area, and there is no long-term follow-up of the infants who are experimented on in these studies. And that's the end of the essay.